Again, I want to welcome everybody to the School of Medicine and Dentistry and to our Meliora weekend. I am Mark Talbot. I'm the Dean of the School of Medicine and Dentistry and the CEO of the Medical Center. And I think you're really going to enjoy the next couple of hours. I hope you do. What we really wanted to do is to highlight some of the most exciting work that's being done at the medical center, both in regards to clinical work, research, and education. These are short talks. We hope we will have a little time for questions, but our first speaker is Dr. George Alfieris. Dr. Alfieris is the Chief of Pediatric Cardiac Surgery and the Ganatra Endowed Distinguished Professor of Surgery. He started at Georgetown, then completed his general and adult cardiac surgery training at the University of Rochester, then his pediatric cardiac surgery fellowship at Seattle Children's Hospital, and began working as an adult pediatric cardiac surgeon at SUNY Upstate in Syracuse for quite a while. And we were fortunate enough to induce Dr. Alfieris to come here. And I think that the thing that is most important to realize is that upstate New York, and I'm now talking as a Brooklyn boy, so for us, upstate New York was anything outside of New York City, Long Island, and the small part of Westchester. But upstate New York does not have the volume to have many places doing the highest end pediatric cardiac surgery. And what George has been able to do is truly unique in crafting a program that involves Buffalo, that involves Syracuse, and that involves Rochester, and therefore allows us to be a mecca for pediatric cardiac surgery, which we could never do as a single institution. So please welcome Dr. George Alfieris.
Thank you, Dr. Taubman. I really appreciate the opportunity. Dr. Taubman heard me give a grand rounds earlier this year for the Department of Surgery and asked me to give this talk. And when Dr. Linehan, who's also here in the office, the chair of surgery, asked me to give the talk, I thought about what I wanted to talk about. And this is really more of a story than it is anything else. And I'm going to talk about the story of pediatric cardiac surgery in upstate New York and my thoughts about it and the way I think that how it has evolved here and how it should be evolving. And I called the talk "Going the Distance." I've had multiple opportunities to leave Rochester. I love Rochester, and I've decided to make my entire career here. And part of that was driven by this philosophy that you're about to hear about. The story starts when I became a surgical intern in 1987. And during that time period, I had to rotate onto the pediatric general surgical service. Dr. Emmons and Dr. Putnam, many of you will remember those names, great men. But the guy who really stuck out during that rotation was Dr. Manning. And I'm sure many of you remember Dr. Manning. Dr. Manning was the chief of pediatric cardiology. He instilled fear in everyone whose path he crossed. You had to, he was just a brilliant guy and a great physician. And when I was on the pediatric general surgical service, I would see once every week, once every 2 weeks, a baby come into the neonatal ICU. I'd be making rounds, taking care of the pediatric general surgical patients, and I would see this blue baby, and a couple of days later, the baby would be gone. And I would approach, and at one point, I approached Dr. Manning, and he gruffly said, "What do you want?" And I said, "I just want to understand, Dr. Stewart, who was a very, very good congenital heart surgeon who was here at the University of Rochester, is not doing these babies. What's going on with that?" And he said to me, "Listen, this is a small program. these complicated babies need to go elsewhere. They go down to Columbia Presbyterian by and large. And this is always going to be a small program, and nothing's ever going to change, because you can't change the situation where you don't have the ability to draw a huge volume. And in fact, Dr. Stewart did much less than 100 cases, pediatric cardiac surgical cases a year, probably on the average of 50 cases a year for his entire tenure. He also did adult heart surgery, but this philosophy of you had to be at a large center really was paramount. And that kind of was borne out over the years with, if you do a pub med search on surgical volume and outcomes, you can see the number of publications per year growing from 77 to 2000, the end of 2022. There was a peak of 5,700 articles in PubMed, if you searched it, about how surgical volume improved outcomes. It improves morbidity, improves hospital mortality, and it improves long-term survival. When you look at pediatric cardiac surgery, and you hone in on pediatric cardiac surgery in particular, it becomes very, very difficult, because there's so much in terms of understanding it, because there's so much anatomic heterogeneity. There are thousands of diagnoses. There's 75 or 80 index operations. There's all kinds of combinations of those operations. And so there's, a nearly infinite amount of combinations that allow you for procedures. But what is also very clear is that as the complexity of anatomy progresses, you become more and more complex. You have less and less volume of that. It's an absolute inverse, linear inverse relationship between complexity and volume. And so that makes it a very difficult situation. And through the course of the 80s and 90s, and even now to today, there has been a call for centralization. Now, people will call it regionalization, but it's really not. It's centralization. It is this call for all children to be moved to large children's hospitals, where there can be large volumes, where there can be the resources that go with that, all the pediatric subspecialties. And that has really been the call. And in fact, Dr. Manning was very clear that that's what needed to happen. People need to go down to Babies Hospital. Children need to go down to Babies Hospital at Columbia Presbyterian in New York City, Manhattan. And that's what happened for years and years here. And so this culminated really in a theoretical paper that looked at the patterns, the travel patterns, and the surgical patterns of pediatric cardiac surgery in the United States of America through 2019. And at the time that this study was done, it was using an administrative database. There were about 153 hospitals in the United States of America that performed pediatric cardiac surgery. And they were very evenly split. If you said, okay, who did 50 cases or less, who did 150 to 50 cases, and who did greater than 150 cases, it turns out 1/3 in each group. Third of those hospitals, basically 50 hospitals did less than 50 cases or up to 50 cases. 50 hospitals did somewhere between 50 and 150 cases, and 50 hospitals did greater than 150 cases. And when you looked at the travel patterns, you can see the travel patterns of every individual patient in a block of time. The median distance of where patients traveled was about 39 miles away. And there were a quarter of the hospitals, 25% of the hospitals, were within 25 miles of another hospital or institution that performed pediatric cardiac surgery. When they looked at, they decided that if they were to say, okay, let's get rid of 2/3 of these hospitals, or these university programs or hospitals doing pediatric cardiac surgery, and only the programs, the 50 programs or so that did greater than 150 would do all the surgery. The patient distance would move up to 131 miles from 39 miles. So you're adding 100 miles of travel, but the mortality overall dropped 6%, which is a massive number, a very impressive number. And so this further has pushed this theory of centralization and needing centralization. So now but again, this paper, and I want to be very clear about this, they use the term regionalization, but this is not regionalization, and you're going to understand that hopefully in a couple of minutes. with this background in mind, not that paper in general, but the entire, but Dr. Manning's admonishment to me that I had to go to a large children's hospital and I had to be in a big place. With that in mind, I set off for Seattle Children's, and as I trekked across the United States of America in my Saab in 1994, I thought to myself as I was pulling away, well, I'm never going to be back in Rochester. It's been an incredible 7 years. I did my general surgery with Dr. Schwartz, Dr. Adams, and you all know those cast of characters, and Dr. Deweese. And I did my cardiac surgery with Dr. Deweese, and Dr. Green was a vascular surgeon, Dr. Hicks, who may hopefully is here. It was a tremendous training, but I thought to myself, I'm never going to be back. You know, this is it for me in terms of a small children's hospital, which there wasn't even a children's hospital, the rest of my career is going to be spent in a large children's hospital. And Seattle Children's, for that matter, is a regional center, or a centralized center, if you will, for all of Washington State, for Idaho, for Wyoming, for Montana, and for all of Alaska. And so I went there, and within a course of a year, I was involved in over 400 children having heart surgery, being flown in from all over the place. Frequently, I was on one of those jets or helicopters going to get a sick kid and bringing them back. And it was a really fascinating experience. And so, and I look forward to my future. Well, it turns out that when I finished a year later, there were no jobs available at any of those large children's hospitals. The market had started to become saturated, and I had to start looking elsewhere. And I quickly realized that I was going to end up having to take a mixed job doing kids and adults, pediatric and adult cardiac surgery. And if for those of you who are familiar with the situation, once you train doing congenital heart surgery, you really don't have any interest in doing adult heart surgery. It's a completely different field, even though it shares the cardiopulmonary bypass machine and it shares some elements of the postoperative physiology. It is, you know, congenital heart surgery is in general reconstructive surgery of the heart. Adult cardiac surgery is in general palliative surgery of the heart, and they're completely different things. But as luck would have it, I had to end up taking a job, and having spent 7 years in Rochester, I ended up in Syracuse, New York, where 90 miles away, where I had never set foot. I had never set foot in Syracuse, New York, at Upstate. And I met this incredibly talented group of pediatric cardiologists there. All of them trained at very large hospitals, all of them in Syracuse, New York, for one reason or another, and a very, very vibrant program, who also shared had learned the philosophy and shared the philosophy of centralization and sending patients away. And when you looked at the regional landscape at that time, this is now 1995, there were 4 academic medical centers doing pediatric cardiac surgery: Buffalo, Rochester, Syracuse, and Albany. The only one truly private institution was the University of Rochester. All of them doing somewhere between 50 and 80 cases a year, barely hitting 100 cases. And it was impossible for any of these programs, really, with the exception of one guy, you may remember the name Subramanian, Valvar Subramanian, who had come from abroad to Buffalo Children's and was able to bring a large international practice with him. So he was probably the only one who ever was able to accomplish a pure congenital program in upstate New York, for a pure congenital practice for himself in upstate New York. All of these teams had limited experience. When you're only doing 50 cases a year, you're averaging 1 case a week. It includes the operating room, includes the anesthesiologist, includes the ICU, includes everything. And despite having a pediatric cardiac surgeon on site, almost every pediatric cardiologist in upstate New York was able to make the case to themselves when they met a brand new baby, complex baby, to send it out to a larger center. And this resulted in the groups competing for patients. And when you see the reality of what was going on, you see these pediatric cardiologists going at each other, including Dr. Manning, tooth and nail, fighting for patients. You could see that in Buffalo, they started encroaching on Rochester. They went to the southern tier. They were in Batavia. The Rochester pediatric cardiologists went to Batavia as well. They went into Syracuse. Dr. Manning had a clinic in one of the high schools in the city of Syracuse, one evening a month, trying to steal patients from the Syracuse group. He also was fighting in the southern tier. He was toward the Ithaca Elmira region, and he went. Of course, his beloved Watertown, where he loved to fish in the rivers there. He went as far when he drove past Syracuse right into the Utica Rome region. The Syracuse guys did the exact same thing. And the situation was a mess. Everyone was fighting for patients. It was, and despite all of that, patients were being sent out. So when you look, so that was the landscape. When you look at the centralization problem, going to a large institution, you realize that there are several problems. One, where does the patient receive care afterward? Goes to New York City, has surgery, but then what? Families, especially in complicated neonates, they're usually in the hospital for 3 weeks or a month. The family's stuck there in a hotel. It's a difficult situation. They're away from their other children. They're away from their work. It's a difficult thing. Where are all subsequent procedures performed? Turns out that most of the time, the families are now ingrained to go back. If anything goes wrong, they need to go back to New York or Boston or Philly or wherever else they are, where postoperative complications are cared for. The kids will come back within a couple of weeks, start having a problem, even just as simple as wound infection, ship back. There's a tremendous, in this situation, there's a tremendous degradation of local care. And that's what happened. If you're not caring for these children, you can't care for these children. And you can see that having come from Seattle Children's to Syracuse, recognizing very quickly that I could lose my skills if the thing stayed the way it was. And there was a tremendous amount of information lost between, especially before the advent of electronic record, medical record, there was a tremendous amount of information lost. And of course, not lost on the administrators of the hospital, there's a massive loss of finances to the referral center, by the referral center to the other center. So when I was in Syracuse in 1996, Dr. Cavey, one of the cardiologists in that group, asked me to look at this paper that was about to be published by the Cardiac Advisory Committee in the state of New York, a very aggressive committee looking at outcomes. And it was a great paper, and it really sparked an idea on me. It showed that when 7,000 cases were analyzed by New York State, that hospital and surgeon volumes were independent predictors of mortality. In other words, if a hospital had a large volume, they did much better than a low volume hospital. And if an individual pediatric cardiac surgeon in New York State did a large volume, they had a better outcome, statistically significant better outcome than if you were a low volume surgeon. And the fascinating thing about this paper was that you could a low volume surgeon could go to a high volume surgeon could go to a low volume center and make it work. So this is where the regionalization concept came from to me, where we were all close to the university hospitals. We needed to change from a competitive model to a collaborative model. And I started petitioning the cardiologists in all the cities to develop a regionalized program. And when we did that, we decided we would have a collaborative effort. Each group would assume different responsibilities, and we would share our resources. First attempt was very, very difficult in 97. Second time in 1999, we made it work. In 2000, Buffalo joined in, and it became very clear in 2003 that there were clear-cut differences between URMC, which had poured a lot of resources into the situation, and the state institutions. So we restructured the relationship. We added a second surgeon in 2006. Dr. Banks is here. That was Dr. Gangemi. And we worked on an arrangement where we allowed all the patients to be cared for, by and large, complicated patients in Rochester, and the easier cases or the simpler cases in the other cities. And when you look at this was pre-regionalization. Here's post-regionalization. Everyone took their own regions. Everyone stopped competing against each other. And in terms of Rochester, we went from a 12-bed pediatric ICU that had 4 dedicated beds to a 22-bed ICU with 10 dedicated beds, to a children's hospital with a dedicated pediatric cardiac ICU with 16 beds, and then added a Ronald McDonald House for families so that they did not have to stay in hotels and be away. When you look at pre-regionalization versus post-regionalization, you can see a tremendous amount of support staff has been added. The institution has grown by leaps and bounds. People are going back and forth between the cities to help take care of these children. We have developed ICU fellowships, pediatric cardiology fellowships, pediatric cardiac ICU fellowships. We have a non-accredited pediatric cardiac surgical fellowship at this point. And when you look at the data, you can see several things. Number one, a very abrupt rise in the number of cases done at the University of Rochester during the time period. When you look at the combination, you can see that even though Syracuse and Rochester were working together, we still grew overall. When you look at Albany, which declined to participate, you see them being very stagnant. And when you look at the outcomes are dramatic. When you look at children less than a year of age, before regionalization, by the New York State database, nearly 10% of those children died in upstate New York, having a biventricular repair. In other words, having a left ventricle and a right ventricle and getting a repair. That dropped dramatically to less than 2% and has stayed that way ever since. When you look at us compared to New York State as a whole, we were above the average. We are above the state average of mortality. We are now significantly below the state average. And in fact, right now, the University of Rochester Medical Center and its collaboration does the highest risk cases in all of New York State. And it's been that way for about 10 years. When you look at our estimated mortality risk, it is significantly higher than Columbia, NYU, or any other place. So in conclusion, centralization of pediatric cardiac surgery, everyone going to a large children's hospital, absolutely increases cases for the hospital. They have better hospital outcomes. It's a greater burden on the family. Post-discharge care it can be challenging, and there's complicated long-term issues. When you look at regionalization, we have the same thing: increased cases, much better outcomes. Hospitals and children and families are cared for within the region. There's seamless post-discharge care. There's better continuity for long-term care. But most importantly, it leads to a more advanced healthcare system. I wish I had a lot more time. Thank you very much.
Yeah, I think I'm not sure we have time for questions. Maybe one or two questions.
How do you identify the data by payer mix? Does payer mix come into your equation of referral patterns and your outcomes?
That's a great question. And I'm stumped to an answer that I actually don't know. I never look at the payer mix. We take care of every single child that comes. We never look at it. I don't have an answer to that. I've never been asked that question. It's a great question.
In the oncology literature, they do have some payer mix data with allows for improvement with that, but I think that'd be an interesting project for you to look.
I'm a pediatric urologist, and we have a similar issue with kids with collateral. Very, done. Lots of places were doing them. They weren't getting great results. And then our department got together with Children's Hospital of Philadelphia and the Children's Hospital in Minneapolis, and we formed a consortium where the doctors went. Whenever we did a case, all the doctors came to that one hospital to watch, and we talked about it as the surgery was being done, and we improved our care. And it went around to each of the fellow in our department goes to Philadelphia, goes to Minneapolis, and it's improved the care of the quality and the care and the aftercare of all these children. So it's a very similar parallel.
So that's very impressive. And New England has had that history for a long time. The New England Cardiac Consortium, the cardiac surgeons traveled all over New England, looking at the different systems and trying to discern before data became publicly available to elevate each other. And so it's a great model.
Right. Aldo Castaneda and Bill Norwood were the people involved in that.
One more.
How did you overcome competitive self-interest and achieve collaboration?
With a baseball bat. I guess I would say I can be very persuasive. You know, it became very clear to us that we were going to be cannibalized by Boston Children's or by CHOP or by New York. And by the way, when you regard to the payer mix, if you're a child without insurance or Medicaid, you were being forced to go to New York. You know, you didn't have the opportunity necessarily to go to Boston, or you didn't have the opportunity to go to Philly. And it became really, when I put it all in front of the pediatric cardiologist and said, look, you guys are beating each other up. You're getting nowhere. You haven't gotten anywhere in 50 years. Let's try something different. I promise that I will have the best interest of everybody at heart. All of our decisions will be made as group. I mean, it is you know, I hate to say it, it's a little bit of a benevolent dictatorship. I mean, you know, I solicit everyone's opinion. We are constantly talking about it, and we have a democratic process, and it's worked out incredibly well.
So, you know, I will say one thing and then we have to move on, because aside from the fact that I think that you can see this is a remarkable achievement, something that we have to be incredibly proud of. But he is a pilot. And what you may not know is that probably one morning he is in Buffalo, another morning he is in Syracuse, another morning he is in Rochester, seeing the patients, evaluating the patients. And I think that the challenge is going to be in the future, in order to keep this together, we probably need another pilot. So we now think that part of the training in the pediatric cardiac fellowship will have to be how to fly.